Thank you, and good morning. So we're going to get started with our presentation of a teenager with complex Crohn's disease. So a little bit of background about our patient. KL is a 19-year-old male who was diagnosed with Crohn's disease when he was 6 years old. At the time, he had gastric and ileal involvement, and of course, at that time, he was also not a smoker, but when he presents at age 19, he still does not endorse smoking, which, as we know from our great talks this morning, is an important risk factor. His symptoms were primarily diarrhea and abdominal pain. So what we've done for this case, because it is quite complicated, is given you a little bit of a timeline, which we will gradually add to as we move through the case. As I said, he presents with diarrhea at the time of diagnosis. His initial therapies included 6-mercaptopurine and mesalamine. His therapies were later escalated to infliximab. He developed a loss of response later in therapy and was then changed to monotherapy with adalimumab 40 milligrams every other week. At this time, he presents with a change in his symptoms. He's developed a relatively acute onset of early satiety. He's experienced a pretty significant weight loss of about 15 pounds over 1 month that he says was non-intentional. He's endorsing pretty significant epigastric pain that he says is worse when he eats. So he goes to see his gastroenterologist, who performs an upper endoscopy. And what he finds is an antral stricture, and he performs a balloon dilatation. So as we move through our timeline, we now see that our patient, KL, presented with early satiety and weight loss. He actually ends up having 2 EGDs in a period of 4 weeks for this antral stricture, and he now presents to us with persistent nausea, epigastric pain, weight loss, and questions of where do we go from here? So what is our next step? We could consider high-dose oral or IV corticosteroids. We could perform a repeat endoscopic dilatation. We could consider an endoscopic injection of corticosteroids. We could get some additional imaging, or we could refer him to our surgical colleagues. So actually, we decided to proceed with additional imaging to make sure we really understood the extent and severity of his disease. This is actually an X-ray from the upper GI series that he had performed in March of 2013, because we thought it really well illustrated his significant upper GI tract findings. Let me see if I can show here. So as shown here, you can see that he has a very abnormal duodenum. The mouse. Right here, which has a corkscrew-like appearance, perhaps the narrowing here at his antrum, and then the corkscrew appearance with multiple strictured and stenotic areas. So the question is, what is our diagnosis? Menetrier's disease, intestinal tuberculosis? Should we be considering a gastric malignancy in our young patient? Or is this, in fact, a presentation of gastroduodenal Crohn's with small bowel strictures? His diagnosis was gastroduodenal Crohn's. He was found to have 3 high-grade duodenal and jejunal strictures. So this is one of these questions we'd like you to think about, and hopefully through the course of this presentation you'll know the answers. But which of the following statements about gastroduodenal Crohn's is false? Most remain asymptomatic. Pain improves with antacids or oral intake. Symptoms include nausea and vomiting, and symptoms occur in 5.5% of the patients who have gastroduodenal Crohn's. So moving along, let's talk a little bit about the epidemiology of gastroduodenal Crohn's. As you guys have probably experienced both in practice and know from the literature that it's actually pretty uncommon. It occurs in 0.5 to 4% of all patients with Crohn's disease, and that does not include those who have an H. pylori gastritis at the time of diagnosis. It tends to be isolated to the stomach and the duodenum, and it accounts for less than 0.07% of all cases of Crohn's disease. When we start to look at the prevalence, we see that the data is quite similar with very low rates of 0.5 to 13%. And unfortunately, there's just a real paucity of data in this area, and there have been no prospective studies to really characterize this unique population. There are some really important definitions that are very specific to upper GI Crohn's disease, and I just wanted to highlight a few of them, which include the bamboo joint appearances that you might see in the stomach, as well as the longitudinal and irregular ulcerations and erosions that you can see both in the stomach and the duodenum. It's also very important to remember that signs and symptoms may be really quite subtle, and in fact, the majority of patients remain asymptomatic. We only see symptoms in about 5.5% of our patients, which is why it might be very important to consider this point when you're performing endoscopy as well as colonoscopy. The primary symptoms include nausea and vomiting, and epigastric pain is not relieved by antacids or food intake. Less common presentations, particularly in our pediatric patients, which is of great importance to me, is the impairment of linear growth as well as delayed puberty. We might also see mouth ulcers, clubbing, chronic iron deficiency anemia, extraintestinal manifestations that are preceding the gastrointestinal symptoms, as well as the arthritis, arthralgia, and osteoporosis. So what about our treatment options for gastroduodenal Crohn's? Well, unfortunately, there's a real paucity of data. We know that proton pump inhibitors may be useful, particularly when they're used in combination with our immunomodulators. However, there's really no data in this area. We also know that mesalamine is probably not indicated for this patient population unless they have concurrent colonic disease. There's also limited data about the steroid use in this population. They are likely beneficial if patients have non-obstructing disease, but again, we don't have much to guide our treatment here. Methotrexate as an immunomodulator may be useful, but we do not have data. I guess you guys can see a recurring theme here. No data, no data, no data. If we look, thankfully, we do have a little data about the immunomodulator 6MP or azathioprine, which of course is used as a steroid-sparing agent. Correlates reported on a 20-year experience and noted that 100% of his patients who had gastroduodenal Crohn's had healing or marked improvement of the symptoms. When we look at our anti-TNF-alpha data, we really have, again, a paucity of information, but we do have some case reports with mixed results showing some improvement in patients and others with less benefit. And we know that endoscopic balloon dilatation, as our patient underwent, can be used, but is best for single, short, and moderately thick strictures. So what about our patient's course? So we know that he had an upper GI series that revealed these 3 high-grade upper GI tract strictures. He was admitted to the hospital and, of course, made NPO. Our surgery colleagues were consulted. In the meantime, we did initiate therapy with methylprednisolone, 20 milligrams IV twice daily. And it is really interesting to note that although it was a very short time course, he really had no improvement from steroids, and incidentally had been tried on them as an outpatient and had no benefit in that case either. He then underwent stricturoplasty on 3 different strictures. And so again, here we can summarize. We have our patient who initially presented with a more colitis-like picture with Crohn's disease of the ileum and the colon as well as the stomach. He was initiated with his 6MP. He was escalated to infliximab and then changed to adalimumab due to loss of response. He now has a real change in his clinical course and phenotype, requiring both balloon dilatations and stricturoplasty. Following surgery, we then escalated his adalimumab therapy to weekly and added methotrexate, 25 milligrams sub-Q weekly. So at this point, our patient does really well, and then he comes back and he has, again, anorexia, a 5-pound weight loss, nausea, postprandial abdominal pain and bloating. He's again admitted and undergoes repeat upper GI series, which again shows more aggressive stricturing disease, where it's shown here by the white arrows, where he has a circumferential focal stricture in the mid-jejunum. So unfortunately, our patient has to go back to the OR, and undergoes an XLAP with upper endoscopy that again reveals that his initial stricturoplasties are normal and appear widely patent. However, he has a new moderate focal stricture within the mid-small bowel, and he undergoes a Heineke-Miklowitz stricturoplasty, which, as technique shown here, involves a lateral incision and sutures running in the opposite direction to increase the luminal size. So just to summarize, we now have our patient who has undergone multiple stricturoplasties as well as an escalation of therapy. And from here, I'm going to pass it on to my colleague, Dr. Shivi Siva, who's going to tell you a little bit more about our patient's course.
I'm an advanced IBD fellow with Dr. Rubin. So I just started. Taking over KL's care from Dr. Stacey Khan, he was symptom-free for about 5 months and then came back to the clinic with symptoms of loss of appetite, anorexia, as well as early satiety. He has also started losing weight significantly. So we repeated the upper GI series, which showed 2 short segments areas within the focal narrowing in the mid-jejunum. So we went ahead and checked his adalimumab levels, and which were within therapeutic limits, and there was no detectable antibodies. So as a result, we ended up doing a gastroduodenostomy. So this brings us to a brief discussion to decide how to choose appropriate surgical techniques. Should it be stricturoplasty versus gastroduodenostomy? So a brief summary. I've decided to highlight 2 studies. One is a Birmingham study by Yamamoto, which showed stricturoplasty patients have early post-operative complications compared to their counterparts who undergo bypass surgery. The median follow-up for these patients was at least a minimum period of 142 months. In contrast, the Cleveland study showed equal outcomes in both groups, but the significant drawback here is the median follow-up time was much shorter. It was 42 months. So in summary, comparing the 2 studies, both Birmingham as well as Cleveland Clinic study, the Cleveland Clinic study was equally good and comparable good efficacy, however, it was limited by short follow-up time. Tonelli et al. Studied the procedure much more thoroughly and came to a conclusion that patients with strictures in their second and third part of duodenum would be far more suitable to undergo stricturoplasty as those compared to those who have multiple strictures either in their first or the fourth part of the duodenum. And both procedures have equal number of complications in the post-operative period. Stricturoplasty can lead to gastric emptying, and 24% of all patients would have gastric emptying delayed scans. They also have anastomotic leaks, intracutaneous fistula, and intra-abdominal abscess and stromal ulcerations. A meta-analysis by Yamamoto showed the overall complications for jejunal and ileal stricturoplasty was about 13%, and the septic complication could be low as 4%. So just to highlight, the commonest indication for bypass surgery happens to be duodenal obstruction, and there are 4 other techniques which the surgical colleagues can describe better, but just to touch upon them is gastroduodenostomy with highly selective vagotomy, gastroduodenostomy, and Roux-en-Y gastroduodenostomy. So this was a question we decided to put up just to highlight treatments, options that you may have post-operatively. One of them was tacrolimus, vedolizumab, repeat endoscopic dilatation, and exclusive enteral nutrition. And we decided to advocate exclusive enteral nutrition. And there's another question, a follow-up question that we would like to highlight. That exclusive enteral nutrition has all of the following effects except downregulates inflammatory cytokines, reduces CRP and ESR, superior mucosal healing compared to corticosteroids, and is only effective when using elemental formulas. So a brief summary on exclusive enteral nutrition in Crohn's disease is the underused therapy. The nutrition, using enteral nutrition can induce remission just like corticosteroids. The formulas are available both in elemental and polymeric forms. The duration for induction is usually 6 to 8 weeks. They could be introduced both orally as well as nasojejunally. It's both useful in pediatric population as well as adults. However, there have been much controversy as to should the disease location impact the efficacy of EEN. So far, the studies that have been conducted have been controversial, and we don't have a consensus on this subject. Just going into prospective studies that have been done on this area, there were 3 prospective studies we identified to show you. One of them was the open label RCT by Borelli, which showed higher mucosal healing of 74% on a polymeric formula as compared to corticosteroids, which induced remission in 33% of patients. And an open label prospective study which showed a decent clinical remission and biochemical remission. However, the transmural remission was much significantly lower. And there was a prospective study which also showed 80% achievement of complete mucosal and microscopic healing in colon and terminal ileum. So this was a slide we wanted to highlight to show that IBD does break down intestinal permeability and can also break down the integrity of tight junctions, whereas the polymeric formulas have the ability to reverse this effect. And EN can also downregulate inflammatory cytokines in interleukin-1 and interleukin-8, and this has been shown both in vitro and in vivo studies. It also reduces serum inflammatory markers, including TNF-alpha. So speaking about pathophysiology of EEN, this is based on the hot topic of gut microbiome. So this dysbiosis hypothesis explains that the great balance between harmful bacteria and the beneficial bacteria could lead to IBD. And both in vivo and in vitro studies, EN has shown that it can significantly modify this balance and can lead to anti-inflammatory action. And this effect could last up to 4 to 6 months and may lead to induction of remission. So this particular 4 studies that we wanted to highlight is especially useful in the pediatric population because EN has shown to reverse the growth hormone resistance, can improve bone health, and also may improve micronutrients. So Kale comes back to our clinic and is puzzled as to why he has such severe disease and why is it so difficult to treat. And we explained that some of the features that Kale has in his lifestyle, especially as a teenager with dietary modification and lifestyle, could lead to worsening disease. Also, with his previous surgeries, he has developed small intestinal bacterial overgrowth, and therefore he could have severe disease, and also the medications. We also will touch upon this genotype, which I will speak later. This was a study that Dr. Hanover mentioned briefly, where he said the teenagers tend to have more severe form of disease compared to the adults. This was a study that was conducted by James Goodhand, a fellow in training at Barcelona, London with me, where he compared 100 adolescents with 100 adults and showed the ileocolonic disease and the gastroduodenal disease is far more severe in teenagers compared to the adult population. And they also needed more azathioprine immunomodulators and biological agents compared to the adults. This was a genetic slide that we wanted to show because Mardani showed that genetic polymorphism could influence GDCD, particularly L107P homozygosity could lead to GDCD in a younger population at diagnosis. So take-home points from our discussion today is that gastroduodenal Crohn's disease is extremely uncommon. It's usually asymptomatic, but patients do present with nausea, vomiting, weight loss, and obstructive symptoms. And there are multiple surgical options available, but it's all based on the location of the disease, the extent, and the patient's response to past therapy, and the availability of a skillful surgeon and gastroenterologist in your facility. EEN is a good long-term option. However, the palatability, it depends on the patient's taste. And genetics do play an important role in GDCD. And this is a summary slide we thought will show you. It all depends on patient factors, local availability features, as well as the presentation and extent and location of the disease. Thank you.